Maternal deaths or deaths to mothers as a consequence of pregnancy are a tragedy of global dimensions. The magnitude of women's reproductive health problems is reflected in a number of deaths related to pregnancy and childbirth. In the developing world, the risk of maternal deaths for a woman becoming pregnant is almost 200 times that of such a woman in the developed world. In Tamil Nadu, government is the major provider of primary health care, particularly in rural areas, while teaching hospitals, district headquarter hospitals, taluk and non-taluk hospitals in the state provide secondary and tertiary care in the government health sector. Rural primary healthcare needs are served by primary healthcare centers. Primary healthcare is the most effective intervention to achieve significant improvement in the health status of population, especially in respect of infant, child, and maternal care. While the government health sector in Tamil Nadu entirely employs around 8,500 doctors and 28,000 paramedical personnel, approximately 2,300 doctors and 22,000 paramedical personnel serve in primary health centers. But before 1995, it was not like this. The situation earlier with respect to primary health centers in Tamil Nadu was very depressing. Doctors would often not go to the primary health centers, and even if they did, would definitely not stay for the whole day. Absenteeism was rampant. They were most of the time found closed. There were many grievances regarding lack of proper building, non-availability of medicines, etc. If the health officials were asked about the main cause of maternal death, they would reel off such medical causes as postpartum hemorrhage and anemia, or attribute it to medical causes like late arrival of mother to the institution or willful neglect on the part of family member. The first step taken towards improvement was monitoring of the primary health centers. The system of reporting and investigating of maternal deaths was strengthened. A reporting system was put in place whereby every maternal death occurring in the state would be reported to the project director working for Reproductive and Child Health Project within 24 hours. Each maternal death would be investigated and a report would be sent to the Commissioner for Maternal Child Health and Welfare within 15 days. This reporting system sensitized the health system personnel to the avoidable tragedy that most maternal deaths represent, and thus contributed to greater care and attention on their part in addressing the needs of pregnant women. It was also decided to introduce a system of maternal death audit at a level of the health facility for all maternal deaths. The idea being to analyze the real causes of maternal death. The novel and unique feature of this audit was that besides the medical and health system personnel, the relatives of the deceased were also invited to participate. The objective was to identify the various delays in seeking care, in referral, in transit, and in provision of care after arrival in any health facility, with a view in minimizing, preventing such delays and enhancing the chances of survival of pregnant women. A key to improving maternal survival, especially for the rural poor, was to ensure easier access at all time to a public sector health facility for delivery case. The concept of providing round-the-clock services at primary health centers has emerged in this context. The bulk of the deliveries in both government hospitals and primary health centers were being conducted by paramedical staff. Shifts were started in primary health centers with 3 staff nurses working in shifts to ensure round-the-clock availability. Besides, there were 2 medical officers already available in the primary health center during the day. These staff nurses were also able to handle minor ailments and minor surgeries, and normal services were best delivered through them. As a result of the availability of staff nurses round the clock, the delivery performances of primary health center improved significantly in Tamil Nadu.
All the primary health centers have been made in 24/7. It is a reality, it is a feasible, it is a possible, because the 24/7 means all the PHEs are functioning around the clock. That is, this commitment is made by posting the staff nurses. Almost every primary health center, there will be 2 staff nurses. Even after 5 o'clock, at any point of time, if you go, the PHE will be opened, and it is open for the delivery care services. So there is a drastic reduction in the maternal mortality ratio because of the availability of services close to the doorsteps of the people.
As the performance of the primary health centers started to be monitored, feedback on the gaps in infrastructure came to the knowledge of the higher officials. There were not enough tables, chairs, wash basins, hand towels, labor boards, photoscopes, labor rooms, and many other things. The required furniture, equipments, and infrastructure were supplied to the primary health centers to make it possible for the doctor and nurses to work effectively.
All kinds of programs implemented by the Government of India as well as the health programs from the Government of Tamil Nadu are being implemented through these health sub-centers, which is manned by village health nurse. Every health sub-center caters 5,000 population. So the families in this 5,000 population and breakup of different age groups is available with this village health nurse. She executes immunization, maternity and child health care, and public health program implementation in her allotted area.
There had been a general complaint that village health nurses did not stay in their headquarters. So it was decided to construct a health sub-center, which had a clinic and a residential portion.
We provided them a beautiful health sub-center, and we allowed them, we had a committee which sat down and drew up the design, and with this design we told them that if you wanted, say, a 1-bedroom with a big drawing room or 2 bedrooms with a smaller drawing room, you can make the adjustments. In a kitchen we allowed them to put the shelving. We got them a geyser, we got them gas connections. The place was so attractive that many of the village health nurses in Dharmapuri started staying in their health sub-center.
The involvement of the community and the village health nurse in the design and actual construction of health sub-centers helped in ensuring that the village health nurses stayed in their health sub-centers. The location of the quarters were chosen in consultation with the village health nurse and the community. Where suitable government land was not available, the community either donated a suitable land or got together and purchased a small piece of property in the heart of the village. The initiative of promoting community participation and the involvement of the village health nurse in the construction of the health sub-center from the design stage itself has over the years contributed to improving the share of institutional deliveries as well as the share of primary health centers and health centers in total deliveries in the state, implying a situation where mothers can deliver in institutions very close to where they reside. Today, the village health nurses are seen nonchalantly riding their mopeds in the villages. They serve as role models for adolescent rural girls.
These village health nurses are available on Mondays in the headquarters to look after the population. They give a minor ailment treatment in the health sub-center itself. On Tuesdays and Wednesdays, they visit to the concerned PSC to give immunization, which has now in Tamil Nadu been institutional based. Earlier, it was an outreach session, immunization, where the village health nurse go around the village and eligible children were given immunization. Now that we have switched over to the institutional based immunization program, so these people on Tuesday and Wednesday, they will go to the PHCs. On Thursday, they go to the school health program. On Friday, they have an antenatal checkup. And Saturday, Sunday, they made available in this headquarters itself, and they give a minor ailment treatment for the population they cater in that particular area.
While the rural poor need and are eager to access health facilities for delivery in public institutions, avoidable maternal deaths were occurring because people did not know or have access to facilities where emergency obstetric care would be readily available. Often, a pregnant woman was referred from one facility to another because of lack of facilities or medical personnel in the institution, resulting in the death of the mother in transit or in the referred hospital. In order to minimize delays in accessing delivery and emergency obstetric or newborn care, the Central Emergency Obstetric and Newborn Care, popularly known as CMONC centers, were set up in the public health system, reachable within hours travelled by public transport from anywhere in the state.
To prevent maternal deaths, you will have to do an emergency cesarean section, and we had to have these facilities, and that is how the idea of the CMONC, the Comprehensive Emergency Maternal and Obstetric Care Centers, were born. And we have in every district now in Tamil Nadu, I think about 2 centers in each district. And here I must warn you that once the CMONC becomes very successful, there will be a lot of pressure to have more and more CMONCs. Now, don't do that, because if you have more and more CMONCs, again you will be spreading yourself too thin. So, you will have to borrow one anesthetist and put him here, and you will have only half a surgeon there and half a pediatrician. No, we need to have the entire complement of staff available in one institution, and people in the district must know if there is an emergency, go to this hospital, you will get full care there.
The idea of setting up of CMONC centers was to pool specialists in districts and back up with a fully functional theatre and blood bank. All medical personnel in the district, the pregnant mother and her family, and the community at large were informed that in case of an emergency, they were to go to the CMONC hospital and not waste their time going to the hospitals which may or may not be equipped. Provisions have been made for adequate number of anesthetists, gynecologists and general surgeons, besides staff nurses trained to work in labour as well as in blood bank operations. There are now at least 2 CMONC centres in each district of Tamil Nadu, strategically located to minimize travel time. Most important, the CMONC initiative has ensured service delivery in any obstetric emergency and provided people the assurance and confidence that caesarean can be performed when urgently required. To ensure quality of care, public sector health facilities are required to meet stringent certification criteria before being designated as CMONC.
So another scheme is called the BMON services, that is called the Basic Emergency Obstetric and Neonatal Care. So this activity is being implemented in all the block PHs. In Tamil Nadu, we are having about 385 block PHs. So in this system, all the basic services, like essentially the emergency services, like any postpartum hemorrhage or antepartum hemorrhage, or any system can be, high risk system can be identified. And also the basic lab services, like in the hemoglobin estimation, blood grouping, even the scan test, all the tests are introduced in the in this system.
To make the childbearing experience a less traumatic, birth companion program was introduced to improve the quality of intranatal care in all the primary health centers and government hospitals. A female relative or friend is allowed inside the labor room to provide psychological support to the delivering mother. The delivery process has become a far less traumatic experience for the delivering mother and has also proved to be beneficial for better birth outcomes.
We thought that the mother should not be traumatized during delivery. Of course, it's a painful thing, but it must be made as comfortable as possible for her. So this birth companion initiative was very welcomed by most of the mothers and the relatives. You know, the anxiety of standing outside and not knowing what was happening, that was alleviated to a large extent. But we found that, you know, the higher medical level institutions, there was a lot of resistance. People would keep saying the mothers will be wearing dirty clothes, as if the mother who was giving delivery was not wearing dirty clothes. She was also wearing the clothes that she came in. So really the whole question of, you know, there will be sepsis will come in, the entire antiseptic nature of the delivery room will be spoiled, all that, you know, were more excuses. And I think that every institution, higher level institution, should allow a birth companion into the labor room. Really this helps so that, you know, all sorts of things that go on there, everybody is privy to it and the service will be much better.
This program has also eliminated corrupt practices in the labor room, wherever they existed earlier. Gender inequality and strong patriarchal norms continue to be a part of the social reality. Many families committed female infanticide.
First, what we did know, the government of Tamil Nadu completely created awareness among the peoples of the districts concerned through Kalaipayanam. That is, a troop of peoples will be going, and through folk dances and through the village committee, they will be screening some dramas and folk songs to the community, and thereby we created awareness in the affected districts. That is number one. Then legislation. Whenever a baby is found dead, immediately a FIR was launched. The police took into the, police went in for the investigations. So by all these means, but through legislation, we created awareness among the public. Third one is the cradle baby scheme, which is implemented by the social welfare department. Whenever a baby, whether male or female, is found, they will be put in a cradle and the government will be taking care of the child. This is another scheme. And now recently we have got the scan audit. Usually while doing ultrasonogram, we are not supposed to exhibit the sex of the baby. So by employing dacoit methods and other things, by using our sector health nurses and the public health nurses, we are able to audit the scans. So by the above methods, we are able to control the female infanticide and feticide, sir.
To sensitize the people on the issue of female infanticide and to change prevailing patriarchal values, social mobilization by traveling streets, theatres, and through media campaign was initiated. The campaign achieved a breakthrough and was able to make an impact on the incidence of infanticide. However, it is seen that sustaining such initiatives is a very difficult challenge for a variety of reasons. All the major initiatives have been mainstreamed and are now a part of the regular work. A key to this was that practically all initiatives were formalized through the issuing of meticulous and detailed government orders, as and when the initiatives were being launched.
As regards replication and sustainability, in Tamil Nadu, it's being sustained and we've been growing from strength to strength. So during the last about 5-10 years, we have built on our successes and it has been going on very well. So the model is entirely sustainable. Whether it is replicable in other states, we need to look at a few factors that helped in Tamil Nadu. We have almost 14-15 public medical colleges that is run by the government or quasi-government, and therefore we do get resources a little more easier than perhaps if it is completely a private medical college, because what happens is we are able to offer PG seats. So we say that 50% of the postgraduate seats will be reserved for those who serve in the government service, and once they finish the postgraduate service in our medical colleges, they will have to work in government for a certain number of years. So this helps us to get the resources. So I do not, I'm not sure whether this is possible in all the states, but I think it is eminently advisable that if instead of increasing the private medical colleges, we should increase the number of public medical colleges in each state, which means we will have doctors to serve in our public health institutions.
The Government of India has advised all the other states to follow this model for at least 50% of their primary health centers as part of the National Rural Health Mission.
After the introduction of National Rural Health Mission, we have conducted more than 2.5 lakh deliveries per year in a primary health center. And in addition, Government of Tamil Nadu has launched a scheme called Dr. Muthulakshmi Reddy Maternity Scheme, where every antenatal mother below poverty line is given 6,000 rupees during a period, that is 3,000 rupees in her antenatal period and 3,000 rupees in her postnatal period, to take care of her nutritional status and other things.
The delivered mothers, we request them to stay at least a minimum for 3 days to avoid any postnatal complications. So the mothers are given 3 days, 3 times food, breakfast, lunch and dinner, including in the remote areas or tribal areas, the accompanying person also, either the husband or some in-law, whoever accompanies the pregnant woman for delivery, and he or she is also provided the diet.
The Health Department of Tamil Nadu has only one goal: to make Tamil Nadu the state where the government health sector would be known for the delivery of excellent health services to the entire people.